Yeah, so thanks everyone for joining today. We're going to be talking about glycemic control and type 2 diabetes management in older adults. My name's Wade. I'm one of the members of the Therapeutics Initiative, assistant professor in the Faculty of Medicine at UBC, and I'm a pharmacist as well. So I practice in long-term care here in Vancouver. And I'm joining you today from Vancouver, the territory of the Musqueam people. So yeah, let's get started. I don't have any interests with commercial entities. I receive a honoraria for writing an article in Pharmacy Practice Plus magazine, and I have some research and grant support from the different organizations listed up here on the slide. And my salary is paid by UBC and Fraser Health. And I'll just start by reminding particularly people from British Columbia about the Therapeutics Initiative's prescribing portrait program. So this is available to all family physicians and nurse practitioners here in BC. You can receive personalized feedback on your prescribing, as well as recommendations to support better prescribing and also get CME credits for doing that. So if you want more information about this and are interested in joining, you can visit the Therapeutics Initiative website, or you can just scan the QR code here on the slide. And so the content of this webinar today is actually directly taken from a recent portrait release, which was on minimizing harms of tight glycemic control among older adults with type 2 diabetes. That was accompanied by a therapeutics letter on that same topic. So really what I'm going to be talking about today is derived entirely from that content. And today we're going to review some of the key messages from those resources. And I'm hoping that people will come away with some different considerations that they can apply in managing type 2 diabetes among their people's older patients. I'm going to cover three main topics today. First, I'm going to look at sulfonylureas and insulin for older adults with type 2 diabetes. And then I'm going to look a little bit more closer at A1C targets among older adults. And then finally, we'll get into some of the newer diabetes drugs for older adults, which is always interesting and thought-provoking. And just a reminder that I'm using the term older adults here to mean people 65 years of age or older, but as many of us on the call recognize, there's a lot of heterogeneity in that group. So a lot of the considerations we're talking about today apply more to people who are kind of on the frail end. So something higher than 3 on the clinical frailty scale, which is listed up here. And then some of the considerations are going to apply a little bit more broadly, but I just wanted to flag that before we kind of get into things. So let's start with maybe the easiest one, which is sulfonylureas and insulin. And this is a key message that comes, again, directly from our prescribing portrait on this topic, which is reduce or stop sulfonylureas and insulin in people 65 or older with type 2 diabetes who have an A1C of 7 or lower. So this is kind of the first key message. And why this key message? So as we know, hypoglycemia is a huge consideration for older adults, in particular frail older adults. We know that even a single episode of hypoglycemia is harmful. It can cause things like falls, confusion, and can lead to hospitalizations. So our priority in treating older adults type 2 diabetes should be avoiding hypoglycemia completely. Also because it can be in frail older adults. In this population, hypoglycemia often presents with non-specific symptoms like weakness or dizziness or confusion, which means it doesn't always even get recognized. So it could be happening kind of on a repeated basis without getting detected. So we want to do everything we can to just avoid it in the first place. And at this point, I think it's pretty well established that one of the major things that we can do to avoid hypoglycemia in this population is to avoid use of sulfonylureas or insulin in people that have an A1C of less than 7. And we know from several large randomized controlled trials in the late 90s and early 2000s that using sulfonylureas to achieve low A1C targets increases the risk of severe hypoglycemia. So in the advanced study, the number needed to harm was around 80 over 5 years. And then in Accord, it was around 9 over 3 years. So using sulfonylureas or insulin to achieve strict A1C targets increases the risk of severe hypoglycemia. So we want to avoid those agents. And I think a lot of us, again, probably already know this message, and people say, oh, that can't be a thing anymore. But recent data from Ontario shows that, it very much still is a thing. So a population-based cohort study from 2021 of around 100,000 people age 75 or older that have type 2 diabetes in Ontario showed that around 22% were treated to an A1C of less than 7 with sulfonylureas or insulin. So it seems that treatment to low targets with sulfonylureas or insulin is still relatively common for older adults. And if we look further at that study, which is really, some real world data on management of diabetes in Canada, we can see that there's further evidence on the risk of hypoglycemia with sulfonylureas or insulin in this population, 75 years or older. So this is data from that same cohort study. And they also looked at the risk of hospitalization or ED visit for hypoglycemia. And these top two red lines here on this slide are for people that were treated with sulfonylureas or insulin. And so the very top line is people that were treated with sulfonylureas or insulin to an A1C of less than 7. And then kind of the lighter red line below it is people that were treated with sulfonylureas or insulin to an A1C of 7 to 8. So those two groups clearly had the highest risk of hospitalization or ED visit due to hypoglycemia. And then the bottom two lines is people that were not treated with high-risk agents. So, even if your A1C is between 7 or 8, there's still risk with sulfonylureas or insulin. But obviously the biggest risk comes in those people that are treated with to intensive targets. And so if you have a patient on a sulfonylurea or insulin with an A1C of less than 7, you have some options. So you can either stop the drug outright, gradually taper it with the aim of eventually stopping it, or reduce the dose. There's no particular evidence to guide which approach is best. So obviously we need to consider kind of the individual situation that we're in. So, what dose of a drug is a person on? What is the risk of harm currently? What does their current A1C look like? What does the patient want to do? So you can imagine, different scenarios. If someone's on, glycoside MR 30 milligrams once daily, then, just outright stopping it obviously is going to be reasonable. Whereas you may have someone who's on, higher doses of like insulin glargine, for example, once daily, and then, gradually reducing the dose with monitoring would be potentially a better approach there. So you need to kind of consider the individual situation. And our group at deprescribing.org developed a guideline to give a little bit more consideration to some of the deprescribing issues here. So if you're interested, you can head to deprescribing.org to check out more details. One of the challenging things when it comes to backing off of diabetes medications is that, people have been told for years, get your numbers as low as possible. And people might struggle, with the fact that, what was once considered to be good control is now considered over-treatment. So we need to think really carefully about how we're framing things when we're having discussions with patients. So there's some general kind of concepts or ideas up here on the slide, which have been taken from literature on patient preferred language and our own clinical experience from our group. So one of the biggest things that we often talk about in these conversations is how, people have changed over time, and with advancing age, people are at higher risk of side effects. So it's really about trying to, keep people safe and reduce the chance of side effects as you get older, and that it's normal practice to review medications and make changes when it makes sense. So there's just some things which may be useful in having conversations here. All right, so we covered the kind of the more straightforward issue of sulfonylureas and insulin. So now we're going to talk a little bit more about A1C targets. And so our message from our therapeutics letter on this topic is really to not get too hung up on targeting a specific A1C value. So I'm sure, are all aware of clinical practice guidelines, which recommend, different ranges and targets for A1C. But when we really look at the evidence in older adults, there's really nothing telling us what an ideal target actually is. And I think that's reflected when you dig a little bit deeper in some of the guideline recommendations, which are typically based on expert opinion. And obviously, it's helpful to have some general principles to dictate what a reasonable A1C is for an older adult. And we'll review some of those considerations right now. So I guess one thing we have quite a good sense of is that, and we've already covered this a little bit, is that going too low is probably not helpful and might even be harmful. And again, we come back to some of those kind of landmark early trials in type 2 diabetes, where we see that achieving an A1C of less than 7 compared to a more moderate target of around 7 to 8 does not provide any clinical benefit in terms of things like mortality, cardiovascular events. And then we know that using things like sulfonylureas or insulin to get that A1C down actually causes harm in terms of hypoglycemia. And people will say, oh, targeting an A1C of less than 7 lowers risk of microvascular outcomes. But again, when you look further at evidence on this, it's inconsistent in the trials. And the outcomes used in those trials were typically surrogate outcomes, such as progression of proteinuria or receipt of retinal photocoagulation and things like that, rather than actual clinical endpoints. So we still are not really sure that there is any microvascular benefit in targeting A1C less than 7. Another thing to think about when it comes to A1C, particularly in frail older adults, is that there are different things which can reflect the accuracy of A1C. And indeed, many of the things that are listed up on the slide here are things that are quite common amongst frail or older adults. And it means that an A1C may not actually be giving us an accurate picture of glycemic control. And then we also tend to get, focused on small changes in A1C, but it's important to remember that there's also individual biological variability and also lab error associated with measuring A1C. And so James McCormack published an interesting paper in BMJ, which is listed up there on the slide, which looked at the magnitude of variability associated with A1C measurement. And they estimated that there's around 10% variability in an A1C measurement. So it means that, getting hyper focused on small changes in A1C is probably not going to be doing us any good. Other thing that I just want to mention that raises a lot of questions about the A1C centric focus of treating type 2 diabetes is recent large trials with SGLT2 inhibitors and GLP-1 receptor agonists. So if we look at some of these trials like LEADER or EMPA-REG, you can see that the A1C value that was achieved in the treatment arms of these trials is typically in the range of 7.5 to 8%. Even with an A1C kind of in that upper 7 range, there is a reduction in risk of cardiovascular events, hospitalizations due to heart failure, and important clinical endpoints. So the more recent thinking is that, this clinical benefit is occurring independent of A1C. It's more about the actual drug than the A1C target. So again, that really raises the question of focusing solely on getting an A1C below 7 as a goal. And for people who subscribe to RX Files, they have an excellent section on glycemic targets, and it gives a really nice breakdown about kind of evidence-informed choice of targets. So again, if you subscribe, I would recommend like reading that carefully, or subscribe just to read that section carefully, because it's really useful in practice to try to target or think about A1C goals. Um, and so I would say that the treatment paradigm of type 2 diabetes is again shifting away from kind of a glucocentric approach to thinking more about reductions in morbidity and mortality. And I think people have been pointing this out for years, including the people from the Therapeutics Initiative and people like Victor Montori, who've been writing about it all the way back to 2009. People who are critical of the A1C centric focus of type 2 diabetes would point out that the focus really should be on treatments with established benefit in clinical outcomes in this population, which is potentially things like statins or ACE inhibitors. And then, metformin as an agent itself has been shown to decrease risk of mortality in people with type 2 diabetes. So focusing on clinical benefit rather than just solely focusing on A1C. On the flip side of this, obviously, we don't want, sugars running super high. And particularly, we don't want, symptomatic hyperglycemia. We know that having consistently elevated blood sugar is going to also cause problems, things like dehydration, higher risk of urinary tract infections, and can also affect wound healing. So certainly we're not just going to completely ignore um, blood glucose or glucose control, but really want to think about symptomatic hyperglycemia, particularly in frail older adults. So where does that leave us? Knowing that there's no evidence to dictate, one ideal A1C target. Again, we can just come back to some general principles. So again, particularly in frail older adults and persons with dementia, our major focus, again, is on avoiding hypoglycemia and avoiding symptomatic hyperglycemia. That is, paramount. And that will leave us being pretty happy with an A1C in the moderate range. Remember, we're not saying, ignore A1C completely, just don't get too hung up on it. And I think in terms of guidance, Choosing Wisely Canada and the American College of Physicians both have A1C targets or A1C ranges which are reasonable. Choosing Wisely Canada provides a range of goals based on individual factors, things like life expectancy, comorbidities. And, in theory, this makes sense. And it's not actually necessarily informed by any direct evidence. The principle is that, okay, it's okay to relax these A1C ranges a little bit with increasing multimorbidity and frailty. And again, that makes sense because we want to avoid hypoglycemia and minimize treatment burden as much as possible as, we get to shorter life expectancy and very complex health. And then the American College of Physicians, they're a little bit simpler in saying, most people should have an A1C between 7 or 8. And again, I think that's a reasonable range in the face of existing evidence. Obviously, in developing treatment plans and setting goals, we need to be thinking about individuals. And again, I think that's something we all know. So we want to be thinking about things like, how long has a person had type 2 diabetes? What other health conditions do they have? What is their individual risk of hypoglycemia? What are their goals of care? Are they concerned about treatment burden? Do they have any cost considerations when it comes to their care? So all of these different factors can inform, maybe what A1C range or what A1C you might be happy with. And again, I'll just also mention in terms of useful resources, this American College of Physicians guideline. And I think this group makes really good guidelines, mainly because they give quite a balanced and nuanced discussion of the evidence. And I'm really pointing this guideline out because of that that job that they do of summarizing the evidence surrounding A1C target. So if you're interested in getting a little bit more information about how the evidence informs the current targets, this is a useful full read, I think. Okay, so we've talked a little bit. We've talked a little bit about some of the newer agents already. And when we give presentations about type 2 diabetes in older adults, um, we always get tons of questions about use of SGLT2 inhibitors and GLP-1 receptor agonists in frail older persons, especially when we talk about long-term care. I'll do my best to provide some of the considerations that we've thought about um, with in particular with SGLT2 inhibitors and GLP-1 receptor agonists. So I think the best thing we can say at this point is to think very carefully about use of SGLT2 inhibitors or GLP-1 receptor agonists in frail older adults. So there have been a few systematic reviews and meta-analyses conducted for older adults taking these newer medications. And usually what these teams do is they take a subgroup of people that are 65 years or older that were included in some of these trials, and they compare findings in that 65 or older subgroup with people younger than 65, and they use a type of statistical test to say, is there a difference between findings among these two groups? And some even do this for people 75 years of or older. And these reviews are typically concluding that SGLT2 inhibitors and GLP-1 receptor agonists have comparable efficacy and safety in older adults compared to younger adults. But we can reflect a little bit more carefully on that evidence and those conclusions. And I'll just say here that, it's a very tricky area, and a lot of us grapple with this on a day-to-day basis. So I'm going to go over some of the evidence that I'm aware of, but I'd be really interested in hearing how other people are kind of approaching this in their practice, and if they can share any experience they have using some of these newer agents, particularly in frail older adults. So I'm just going to look at one of the most comprehensive meta-analyses which has been done on this topic. So this meta-analysis looked both at GLP-1 receptor agonists and SGLT2 inhibitors among older adults. And so we'll look at one of the meta-analysis that was done on GLP-1 receptor agonists first. So this figure here on this slide is showing pooled estimates for several different outcomes which were analyzed in GLP-1 receptor agonist trials. And again, the main thing here is they want to see whether there's any difference in these estimates based on age. And as you can see for these various outcomes on the slide here, these authors are finding that there's no evidence to suggest that there is any difference in efficacy of GLP-1 receptor agonists based on age and 65 or older. And then we have a similar figure for SGLT2 inhibitors. And again, we're looking for whether there's any difference in outcomes based on age. And for SGLT2 inhibitors, again, the authors similarly found no difference in efficacy for people 65 or older compared to those who are younger. And then they even say for the outcome of heart failure hospitalizations and stroke, they claim the risk reduction is even more pronounced in people 65 years or younger. And so this is leading authors to conclude that efficacy of SGLT2 inhibitors or GLP-1 receptor agonists is comparable among older adults to younger adults. And again, there are a few other systematic reviews and meta-analyses on this topic, and they're concluding similar things, basically that there's comparable efficacy. But I think there's a few things that are worth mentioning here. And then one of the things is that in these trials, there were very few patients over the age of 75. And that's something that is acknowledged by the review authors themselves. So it's typically around 10% or less in trials. So when we talk about evidence in older adults, in this context, we're saying people 65 years of age or older, but really we're talking about 65 to 75. And that's something to keep in mind. So it's really kind of in that kind of younger, older adult range. And then our usual caveats with clinical trials also apply here. We really don't have a sense from these trials of how many people were living with frailty or had functional or cognitive impairment. Most likely, these people were not represented in the trial, so we don't have a sense of efficacy in this population, which is I think really important to think about because if we just look at the conclusions from a lot of these reviews saying, you know, SGLT2 inhibitors have comparable efficacy in older adults as they do in younger adults, it doesn't give us the whole picture. And so part of that picture is, of course, safety and treatment burden. And there's been comparatively less synthesis, as far as I can tell, on safety of the newer agents for older adults versus younger adults. So I think, you know, many of us are going to be aware of the adverse effects that are common with GLP-1 receptor agonists and SGLT2 inhibitors, and they're listed up on the slide. So again, reviews have been published on this topic. And again, they typically are comparing rates of adverse events in people 65 years of age or older to those younger than 65. And these reviews are similarly concluding that SGLT2 inhibitors and GLP-1 receptor agonists have comparable safety in older adults versus younger adults. So there's similar rates of adverse effects based on clinical trial data. But again, we need to remember who we're talking about here. So the people in trials were typically between the ages of 65 and 75, and we're less sure about the risk in people who are frail or have very complex health. We know in particular for frail older adults, some of these considerations are going to be very important. So if we're thinking about GLP-1 receptor agonists, I mean, I'm thinking about the context where I work in long-term care. We often have, you know, frail older adults whose intake is poor, and we may be concerned about weight loss. So in that context, GLP-1 receptor agonists may not be the best choice. And also because these are injectable agents, we also want to be thinking about whether people have kind of the motor and cognitive skills needed to appropriately administer the drug. So that's also something to keep in mind. Then with SGLT2 inhibitors, obviously there are concerns related to volume depletion, things like hypotension, falls. And so if we have individuals where we might be interested in about the potential for hypotension, that can certainly be a consideration. So again, the safety data that's available from clinical trials may not reflect the risk in these kind of frail older adults where some of these adverse effects are particularly concerning. So I think all of that evidence really, again, just warrants some caution and careful consideration, particularly among frail older adults. So when we're thinking about initiating these SGLT2 inhibitors or GLP-1 receptor agonists, we want to be thinking carefully about individuals and the possible risks for individuals. And that means, you know, thinking about things like frailty? Are we concerned about potential for weight loss? What other comorbidities do people have? What are their goals of care in the context of diabetes? And then if there is a decision to initiate one of these agents after kind of a careful discussion with the patient, it's really important to be monitoring. So for example, with SGLT2 inhibitors, watching blood pressure, renal function, dizziness, and then consider whether there are any other medications which might need to be adjusted. So I think when we think about volume depletion in SGLT2 inhibitors, things like diuretics can also be a concern. And then even while SGLT2 inhibitors have low risk of hypoglycemia in the trials, if people are on sulfonylureas or insulin, there is a potential for increased risk of hypoglycemia. So we want to be mindful of kind of other agents people are on. So just again, being really cautious when we're thinking about these newer agents in older adults. Okay, so that's it for me. We talked about some of these different considerations related to treating type 2 diabetes in older adults, specifically for the SGLT2 inhibitors and GLP-1 receptor agonists. Very interested in how people are approaching this, or if they have any kind of nuggets that might be useful for the group. So I'd be really interested in hearing from people in the chat or if they want to chime in. I'd just like to close by acknowledging some of my partners and colleagues that have been working in this space with me. Obviously, what I talked about today is directly related to the Therapeutics Initiative portrait and letter. So, you know, none of this is possible without the therapeutics initiative, and it really is a team effort to create these things. So I'd like to acknowledge the therapeutics initiative. And then through my work with deprescribing.org, we've also been tackling overtreatment of diabetes for the last several years. So I'd like to acknowledge my partners there. And more recently, been working on a project aimed at reducing overtreatment of type 2 diabetes in long-term care across Canada, and that's co-led by Dr. Lisa McCarthy and Dr. Ileana Lega, along with myself. So just like to acknowledge them as well. And some of the material I presented comes from presentations we've given on this topic. So if you're interested in learning more about this study, you can feel free to contact us at the email listed here on the slide. And so yeah, I'll get to some questions and discussion at this point. So the first question I have is, I think, related to some of the evidence around SGLT2 inhibitors, and say, why are they not running SGLT2 inhibitors against metformin instead of placebo? The trials, so I see Guillaume had some kind of response to that, but I think a lot of the trials, and Guillaume, feel free to correct me if I'm wrong, a lot of the trials are having people that are already on a baseline of metformin, and they are adding SGLT2 inhibitors to a baseline of metformin. That's my understanding. I don't know if Guillaume has a more nuanced understanding of that, but Guillaume, feel free to type in the chat there if you wanna weigh in. And then Johanna is talking about how diabetes is potentially reversible with diet. And then I think Danny's already doing the job of responding to that question. He's talking about sarcopenia. I'm not sure that I'm not aware that there's been any work, Johanna, on like people with older adults, older adults living with frailty and reversing type 2 diabetes there. I think what happens often, I think Janie's kind of alluding to this, what happens, especially in long-term care, from what I see, is that people may have been treated to a certain targeted with specific drugs, and then as they age, sometimes they lose weight, or their intake declines with age, and then they end up kind of losing weight, and they stay on the same medications, and then their A1C starts to fall, and they continue on those medications. Then again, they start having things like hypoglycemia occurring when it previously was not happening. So I think that's kind of what the concern is when it comes to diabetes in frail older adults. But I'm not aware again of reversing. Certainly the need for drugs sometimes decreases as people start to lose weight and their intake drops. But again, I don't know if would call that reversal necessarily. Okay, yes, Guillaume is echoing the statement that yes, people were already on metformin in the trials. Run into issues with SGLT2 inhibitors and mycotic infections. Yeah, exactly. So I think that's kind of where Angela is saying, I've run into issues with SGLT2 inhibitors and mycotic infections in older home care patients, and trying to review if they have adequate pericare in place, or asking about history of mycotic infections before starting. And that's great, Angela. Thanks for sharing that. I think that kind of underscores some of the things that the clinical trials don't tell us. So being mindful of some of those things before starting, and if you sense that there may not be the adequate pericare in place, or a person has a history of mycotic infections, maybe an SGLT2 inhibitor is not the best choice, or you want to make sure some of those things are in place and then consider starting it. So thanks very much. And then Brenda is sharing that, considering the GI side effects caused by GLP-1 receptor agonists, starting these things in long-term care seems like a reduction in quality of life. Yeah, and that's another great comment. And especially when you're considering starting these things, again, if we're thinking about goals of care, and also weighing time to benefit against life expectancy, we may be in long-term care in particular, maybe starting to get into consideration of whether it makes sense to start the GLP-1 receptor in the first place. And if we're going to be concerned about GI side effects, then yeah, that can absolutely have a major impact on quality of life, and it may mean that it's not good to start the GLP-1 receptor agonist in that context. And yeah, certainly I'm not advocating for GLP-1 receptor agonists or SGLT2 inhibitors in frail or older adults. Just careful consideration of risk of side effects and goals of care. And so I think, Brenda, that comment is kind of exactly in line with those considerations. So I think just seeing in the chat a lot of good advice and experience that people are sharing and with their use of some of these newer agents. So I really appreciate that. Hopefully people are reading the chat to kind of get some of these nuggets. I'll maybe have to save this chat so I can take a look at this further after. I think, yeah, the comments seem to really be reflecting some of the concerns about adverse effects with some of these newer agents. Guillaume's asking about DPP studies of DPP-4 inhibitors in older adults. It's a good question, Guillaume. I didn't look at the DPP-4 inhibitor issue specifically in older adults. I know in the context, again, speaking about my practice in long-term care, I think the DPP-4 inhibitors, I think at this point, not necessarily in older adults, but in adults in general, I think it's like established that they don't have clinical benefit in terms of reducing risk of cardiovascular events like SGLT2 inhibitors or GLP-1 receptor agonists. The risk of side effects may be lower. So I think sometimes people will use DPP-4 inhibitors to reduce the risk of symptomatic hyperglycemia in this context, which again is obviously a goal. So you may actually be using them to modify glucose in the context of symptomatic hyperglycemia, recognizing that it's kind of a symptomatic benefit versus reducing risk of cardiovascular events. But I didn't specifically look at some of the hard outcomes in older adults. But I know that for younger adults and adults in general, they're kind of neutral in terms of cardiovascular events. But we do you tend to use them a lot in long-term care, just again for mainly for the symptomatic hyperglycemia issue. Okay, so Allison has another question. What would you consider second line in long-term care after metformin? Again, I think it kind of depends on the individual situation, which is of course the token response. But I think, if you have, as Danny said, depends on CV risk. So yeah, in long-term care, you sometimes have people who, have had hemiplegia after a stroke, but cognitively they're well and their life expectancy might be a little bit longer, but they have that cardiovascular risk. And if their life expectancy is a little bit longer and you maybe are not as concerned about some of the risk of side effects, then you could consider one of the kind of the newer agents. But if it's someone who is, quite frail and maybe the life expectancy is a little bit shorter, and maybe their fasting or random blood sugars are a little bit higher, and you're concerned about symptomatic hyperglycemia, you may be, again, just thinking about trying to reduce the sugar to keep the person comfortable and asymptomatic. And then you may be, again, thinking of something like a DPP-4 inhibitor, which is often what we're using for that context in long-term care. But again, I think long-term care, you can always come back to the goals. You're thinking about, again, avoid hypoglycemia, avoid symptomatic hyperglycemia. So I think you want something that's going to provide those things first. And then secondarily, you may start thinking about, okay, what is the person's life expectancy? What are the goals of care? As Danny said in the chat there, what is their cardiovascular risk? Do we think that we have a reasonable chance of trying to modify that? Is that what the patient and the family want? So it's super complicated. But again, we want to be thinking about the individual situation. I don't think there's any one right answer, but the two major things I would come back to is avoid hypoglycemia, avoid symptomatic hyperglycemia, and then minimize treatment burden is the other thing as much as possible. So there's no one answer, but a few different things to think about that can hopefully help you arrive at the right choice. Just, yeah, thanks everyone very much for attending, and again, thanks everyone who's sharing their kind of experiences and thoughts in the chat. Really appreciate that.